Radhika?
Tell me, ma'am.
Please, that sound on students entering, no?
Yes, ma'am.
Yes,
ma'am.
Last webinar, yes. That's mute, madbudi.
Yes, ma'am. It is done.
Good afternoon. Okay. Good afternoon to all of you. Respected speaker of the program, Dr. Santosh, Sunita ma'am, Principal MES Kishore Kendra, Shantana ma'am, Vice Principal MES Kishore Kendra, my dear colleagues and dear students. The success of any institution or school is measured by the contributions that are made by the alumni of the institution. And Dr. Santosh is an alumnus of MES Kishore Kendra, serving the society and serving the nation at large. And we are indeed honored, privileged, and blessed to have the services of Dr. Santosh today. Now here, as a part of the Science Club activities and the Department of Biology, in fact, has taken the initiative in organizing this webinar today. The webinar on a very interesting topic with minimal invasive surgery, current trends and future prospects. And I have the honor in introducing the guest to all of you. Dr. Santosh is currently serving as an associate professor of surgery at Rajarajeshwari Medical College and Hospital. Is a consultant at laparoscopic surgery, Fortis Hospitals, Pash Hospital, GM Hospital, Nagarpavi, Derma Search Skin Hair Surgery Clinic. Dr. Santosh has graduated from Ramia Medical College and has done the post-graduation MS at Bangalore Medical College and Research Institute. Dr. Santosh is a fellow in minimally invasive surgery, is a member of Surgical Society of Bangalore, Karnataka Medical Council, Association of Surgeons of India, Indian Association of Gastrointestinal Endoscopic Surgeons, Hernia Society of India, Global Association of Physicians of Indian origin. So also has a lot of research and publications to his credit, which include comparative study between Liechtenstein mesh repair and Prolene hernia system in the management of inguinal hernia, sub-investigator in a multi-centric trial of antibiotic product in the treatment of foot infections in subjects with diabetes, sub-investigator in a randomized double-blind placebo-controlled phase 2b study to assess the safety and efficacy effects of ART-123 on subjects with sepsis and DIC, to analyze the type of surgery done, multidisciplinary surgical procedure, antimicrobial use, and post-operative care in patients with diabetic foot infection. Determining foot evaluation done in diabetic inpatients admitted in medical wards and analyzing it through Amit Jain's triple assessment for foot in diabetes. So I do we all wish so would have many more research and publications to his credit. So on behalf of the college principals, staff, and students, I extend a warm welcome to you, sir. So we are very happy and honored to have you with us today. And Sunita ma'am has always been an inspiring and encouraging force in all our endeavors. Welcome, ma'am. We are also happy to have Shantala ma'am with us, joining us today. So a warm welcome to you, ma'am. And all the staff and students, a warm welcome to one and all present here, joining the program. And so, Dr. Santosh is fondly remembered by his teachers here at MES Kishore Kendra as a reserved, well-mannered, respected, mindful of one's own work as a student at MES Kishore Kendra. So I'm sure as Sir would enlighten us on this very interesting topic related to minimal invasive surgery, Sir would also travel down the memory lane and have this nostalgic experience of yesteryears and reminisce the college times when Sir was here at MESKK. So over to you, Santosh sir, to continue with the presentation, please.
Thank you very much, ma'am. Hope I'm audible to everyone.
Yes, you're audible. You're audible.
Yeah, okay. Thanks for those kind words. It's indeed an honor to be presenting in front of all of you. So especially our biology teachers, Sunita ma'am and Anandi ma'am. So yeah, I was at MES from 99 till 98, 99 and 99, 2000. So I was indeed, my biology teachers were my biggest inspiration. I fondly remember still Mr. Sheshadri Iyengar and my Kannada teacher, Mr. Srinivas Sharma also. So yeah, so after I finished my PU, like ma'am told, I did my MBBS from Ramaya, then MS from Bangalore Medical College. And presently, is the screen share okay?
Yes, sir.
Is the PPT visible now?
Yes, sir. You can see the PPT. Slideshow mode, it should come.
Yeah, 1 second. Yeah, is this okay now?
Yeah, yes, sir.
Yeah, okay. So thanks once again. It would have been very nice if I was physically present there at MESKK. Okay. So anyway, okay, at least virtual is now the thing, the trending thing. Okay, so physical or not, okay, huh? It's good that at least we have met up. Okay, so without wasting much of the time, I'll start the topic for today. I'll be speaking on minimally invasive surgery. What are the current trends and what the future holds for us? Okay, so I practice minimal invasive surgery. Okay, it's my area of expertise and interest. Okay, I teach at Rajashwar Medical College, and I operate there. And I also operate a few private hospitals nearby. Uh, as you, if you look at the title for today, it's called minimally invasive surgery. It's a kind of oxymoron. Surgery is supposed to be invasive. Okay, so why it has become minimally invasive and how? Okay, is the question. And what is the use of it being minimally invasive? So let's just go into that. Okay. Um, yeah. So before venturing directly into minimal invasive surgery, okay, what exactly we understand by surgery? What is surgery? Okay. Surgery is a branch of a medical profession which tries to cure a being of his or her disease, okay, by means of invasion. Invasion means, so we do some procedures which are where we violate the patient's body. We cut open his tummy, chest, okay, limbs, with the aim that we cure the disease the patient has been suffering. Okay, so there is some amount of brutality and inhumanness which has been associated with surgery. So this has compelled many a generation of medical physicians, okay, to be wary of, to be they are kind of scared of surgery. Surgery was a kind of a taboo in the beginning years. Okay, so cutting open of a human body, even though just for the sake of curing a disease, was considered a taboo. It was considered blasphemous. So, however, now we are seeing that surgery, okay, has dramatically changed over the past few hundred years. Okay, so now the surgeries have become more and more effective. The violence has been the violence or the whatever the brutality associated with surgery has been tremendously reduced. Okay, it has made a tremendous contribution to the treatment of many diseases. Okay, one of the famous surgeons told his students, okay, regarding what constitutes a basis of surgery. He realized, William Hunter realized that anatomy is the basis, okay, which is very, very essential for the necessary inhumanity. Even he thought that operating on someone is inhuman. So in the initial years, surgery remained a very limited profession, meaning it was not as advanced or as charismatic as the medical profession. Okay, so there is always the danger of the pain and the infection. Okay, so now we are with the advent of anesthesia. Okay, the surgery has become painless or as less painful as possible. But in the beginning, without anesthesia, without proper pain management, it was very, very dangerous thing to be even thought of. Okay. And there are some areas the initial surgeons, initial medical practitioners were very scared of, like opening up of abdomen or the tummy, opening the chest, opening the brain. So if there are diseases in these parts of the body, most of the times they were the patients, or the human beings were just left to die or suffer from the disease. So most of the times, the surgery in the initial periods was limited only to the surgery of the extremities, like the hands and the foot or the limbs. Okay. So before going into the minimal invasive surgery, it is important to know how the current modern surgery has developed. Okay. So like I told you, initially the surgery was a very mediocre or a very limited profession, a profession which was looked down upon. The initial surgeons, as you must have known before, were actually the barbers. So they used to trim beards, they used to cut hair, they used to pull tooth sometimes, and sometimes they used to operate also. So surgery was initial surgeons were actually the barbers. Okay. So earliest references, like we all know, dates back to almost 10,000 BC. Okay. One of the initial Invasive procedures which were done were trephining and bloodletting. Okay, trephining means drilling holes into the skull with the sharp instruments, metallic instruments like this, with the hope of curing the disease. Okay, so the evidence we got at excavation of many ancient civilizations with skulls with many holes like this. So this was used as a treatment for several diseases. Okay, related, unrelated also. Even depression, mania were also attempted to treat with this. Even head injuries were treated by using trephining. Okay, so as you can imagine, the treatment itself was much more dangerous and it was life-threatening than the disease itself. Okay. So the other invasive procedure or one of the earliest surgical procedures which was done was bloodletting. Now, so the phlebotomist or the person who cuts open a blood vessel vein, he used to make a small puncture and remove an ounce or two of the blood from the patient's body. Again, this was used as a cure for several diseases, several unrelated diseases. Sometimes patient used to develop infection. Sometimes patient used to bleed to death. A little later, leeches were used to suck the blood from patient's body. Okay, with the hope that they drain all the impure blood, which was thought to be the source of the disease, and hence cure the patient. So obviously you would have heard about the famous personality Sushruta from India. He was considered as father of plastic surgery. So earliest descriptions regarding surgery, okay, in our civilization were found in Vedas also. Even Sushruta has written a treatise on surgery. He developed several instruments like this. Okay, he advocated several surgical techniques, including reimplantation of the nose, and sometimes ear lobe repairs also. So he was considered as a father of plastic surgery. Sushruta also knew that our understanding of the human body and hence its anatomy would definitely help in doing proper surgery. So he advocated the dissection on the dead bodies. So dead bodies were kept in running water for about a week or so. He thought that will purify everything, it will kill all the germs. So after that, he advocated that the body should be dissected and to be studied upon. So initially, for the development of surgery, there were four major challenges. Okay, we didn't have the knowledge of anatomy, so obviously we'll have a fair idea what anatomy is. Okay, so anatomy tells you what are the structures which are there in a particular area of the body. So what is the limb made up of? What is the chest made up of? What are the structures which are present? How they are related to each other? Okay, so without knowledge of the anatomy, it was very difficult to operate. Okay. So we have to gain the knowledge of anatomy at least to approach the site of the disease or to prevent damage to the structures which shouldn't have been damaged. So our knowledge of anatomy was almost negligible. That was a major impediment. So everything, the knowledge of anatomy was just a guesswork at that time. So other important challenge which was faced initially was pain management. So I told you because of the pain, many people were afraid to undergo surgery. It also limited the number of procedures the surgeon could do. So it also limited the time we could operate on someone. Okay. Nowadays we have seen or heard we are operating surgeons operating for 10, 12 hours. Okay. So, but in the ancient times, when there was no proper pain management and anesthesia, operating someone beyond few minutes was unheard of. It would definitely result in death. So other major challenge which was faced by the earlier surgeon was how to manage the blood loss. Whenever we cut open a part of the body, obviously there is bleeding. The previous surgeons, the earlier surgeons, had never no idea how to stop this bleeding. Even before the patient died of the disease per se, he would have died of blood loss. Such was the implication. So this is another major impediment in the development of surgery. So if the patient has gone beyond all these things, he has sustained the blood loss, he has overcome the pain. Most of the times, a few days or weeks after the surgery, he would have developed infection at the site of surgery and he would have succumbed to infection. Okay. So these four major things: the knowledge of anatomy, the lack of pain management and anesthesia, and the lack of control of bleeding, and improper treatment for infections, all these things were the major challenges faced. So, and hence they kept the development of surgery at check. So how these four challenges were overcome? So I will tell you the important milestones okay, in the improvement of the knowledge of anatomy, the pain management, and blood loss and infections. There are several important surgeons and physicians who contributed to this. Okay, so I'll just pick up a few of the important events which took place to increase our knowledge regarding this. So understanding the anatomy. Okay. So obviously with this photograph, you can understand we have now very nice models, photographs, 3Ds, everything. Okay. We can virtually say what organ lies where, which is, what organ is in front and behind. So with this knowledge, we know what all the things which we have to cut to reach, for example, say a lung or a heart, a liver, what are the structures which are close to each other and how can we minimize the damage. Okay. So one of the earliest contributors to the development of the anatomical knowledge was Claudius Galen. Okay, he was surgeon to the gladiators. Okay, whenever there were fights in the Colosseum, so injured gladiators, injured warriors were taken care by Claudius Galen. Okay, much of his knowledge of anatomy was based on the examination of the wound sustained by them. Whenever the warrior comes with an injury on the thigh, he would examine the wound and he would just have a look into what structures have been cut. So from where it was bleeding, what muscle is there, what bone is there, and he used to write it down and develop his knowledge of anatomy. Okay. So obviously, dissecting a dead body was the ideal way to learn the anatomy. But at that time, the church was against it, and even though Galen knew that dissecting bodies would have been a much better option to learn the anatomy, he couldn't propose it for the fear of the church. So his major work was treating the wounded gladiators. Okay, most of the times his procedures involved limb amputations. Okay, so injury to the limb almost always at that time resulted in the limb loss. So because of his excellent work expertise, okay, he later became the physician to Marcus Aurelius, the emperor of Rome. So there is a famous anecdote with Galen. When he was called for the interview, he was one among the many physicians who was interviewed. They asked Galen what is so special about him, what is his area of expertise. He had taken a monkey with him. He just cut open the stomach of the monkey and he stitched it back and asked if anyone else can do it. So he was a kind of a daring, egoistic surgeon uh, whose early contributions were our earlier treatise of anatomy. So, but like I told you, his knowledge of anatomy was mainly based on the wounds what he examined. So his knowledge was very limited. So, but rest of the areas which he couldn't examine, so he made up things to cover them. He just fantasized that, okay, whatever he just guessed what other structures might be there in the other areas which he couldn't examine, and hence wrote a treatise on anatomy. So later, when the later surgeons and anatomists, they found out that there were several mistakes in Galen's work, okay, which have to be corrected. So the other important contributor was Andreas Vesalius. Okay, he's considered as the father of modern anatomy. This was the period of Renaissance where there was a lot of printing going on, a lot of artwork which was going on. So he was benefited with that. So his interest in anatomy and human body began when he was a medical student. Okay. So in those times, in Vesalius times, so the criminals were hanged outside the city doors and they were left to die. So by evening, just before the city doors gates were shut, Vesalius used to stealthily smuggle these bodies, sometimes just limbs, upper limbs, lower limbs, or whatever part he could get hold of, stealthily take to his room, wash them thoroughly, and he used to dissect. So, doing this repeatedly over several years, he could come up with a treatise on anatomy, which he published. There were two volumes of it which we published, called The Fabric of Human Body. There are several very, very good illustrations which he has given in this book, like this one you can see. So it is just like how the body was there outside the city gates. You can see the landscape there, the hills, everything outside the city of Padua where he was there. So but he was the one who laid the foundation for modern anatomy. Subsequently, there was people developed interest in dissecting the human bodies after their death. He even gave public demonstrations in the hospital to the medical students at that time, and even public demonstrations. So just to show them the structures he has identified and defined. He also identified, all the bones in the human body and rearranged them, wire them into a skeleton, which is still preserved in the museums. So he corrected several hundreds of mistakes which were made by Galen in his treatise on anatomy. So the first major challenge to the surgical development, which was anatomy, was overcome by the pioneering work of these two individuals. So the other major challenge was bleeding. So whenever initial surgeons were mainly used to treat trauma and injuries. So either most of the time sustained during a warfare. So majority of the surgery involved removal of a whole or a part of the limb, and most of the times patients used to bleed and bleed to death, or they used to get infected later. The death rates were as high as 50%. Almost 1 in 2 patients used to die because of bleeding. So the control of bleeding was something which was the pioneering work of Ambrose Paré. He is a French barber surgeon. So during his time, during the French wars with Italy, there were several soldiers who used to get injured by these musket bullets. Compared to the injuries sustained by the daggers, arrows, swords, Paris saw so many different kinds of injuries which were very, very devastating. So he was basically a trauma or a warfare surgeon. Most of the times he used to operate in the battle zone itself. So based on his knowledge, okay, so he published a treatise called Treatment of Gunshot Wounds and Other Injuries by Arrows and Swords. These are few of the illustrations from his book. Like you can see, this might be very simple and silly now, but in 1500s and 1600s, so this clearly shows the various modes of injury to the extremity or the limb, and the various ways of removing the foreign body there. Okay, this is another famous illustration, the wounded man. So the man with 17 types of injuries as described. You can see a dart there, arrows there, maybe a bullet, dagger. So whatnot. What are the, I mean, whatever the weapons which were used at that time, everything has been depicted in this one photograph. So this is how most of the times he used to operate. His operating theater was actually a battlefield. So completely unsterile, no assistance, no controlled environment. So this is where used to operate. So obviously controlling bleeding here was very, very difficult. No proper lighting also. So with a lot of deliberation and work, he came up with what he used to call as crow's beak. So this is the first instrument which was designed just for controlling the bleeding. He thought that whenever the limb is cut, the major bleeding was from a bigger sized blood vessel, what you called as a axial artery. So he thought at least if you control bleeding from that, other small bleeding from rest of the things would be taken care of, and it is not life threatening. So he used to apply this around that blood vessel, and he also advocated tying of these blood vessels using silk. So first attempt at hemostasis, a first proper attempt was made by what is called as crow's beak. So, what the surgeons used to do before the advent of these procedures, meaning clamping a blood vessel and before tying it off. So, there are several ways they try to control bleeding. One way was using hot iron. The iron rod was used, it was kept in a furnace, and it was applied directly to the surgical wound after a limb has been cut. Even Ambrose Paré used to pour boiling oil into the wounds with the aim that it will sterilize the wound and it will control the bleeding. So these are very horrific things even to hear, the application of hot iron and pouring of boiling oil into the wounds, but that's how it was done. So Ambrose Paré was one of the greater advocates of modern surgical knowledge. He told that the duty of a surgeon is to remove what is superfluous or it is growing extra, to restore what has been dislocated, to separate what has been damaged, and to repair what has been destroyed. So Ambrose Paré next major
Doctor, your voice is fluctuating.
hello,
Yeah, now it's clear.
now it's clear.
Yeah.
Yeah. So with after conquering the two major obstacles like control of bleeding and acquiring adequate knowledge in anatomy, the major problem with surgical development was pain. So previously surgery was done like this. Okay, you can see a patient being operated on the leg. So the surgeon has several assistants who are not actually assisting him personally, but they're actually trying to pin the patient down. Because at that time there was no anesthesia, no pain management. The patient was literally pinned down by several men like this. So assistant used to hold the leg, and surgeon with his swift action used to complete the surgery very, very, very quickly. Good amputation removal of the limb will take easily 45 minutes to 1 hour now, but there are several surgeons in the yesteryears who used to complete this surgery in few minutes, in a matter of few minutes. Like I tell you later, in sometimes few seconds also. The main reason being pain. The longer you try to operate, the patient has to sustain for such longer time, which was very, very cumbersome for the patient. So because of this, the yesteryear operation theaters were one of the dreaded places in a hospital. They were usually away from a main building, and almost always they were next to the mortuary. Because most of the times, like I told you, almost 50 to 60% of the death rate was the norm there. It was not astonishing at that time. 1 in 2 patients used to die either because of surgery or because of the disease complications. So these operating theaters used to have very long, thick walls so that the screams of the patient was contained within as much as possible. So this is how most of the times, if the surgeon is famous, he's and very efficient, his surgeries were very well attended. So obviously, if you had gone to operating theaters now into the hospitals, you will see that you will be stopped far, far away from an operating theater room. But if you can see in the yesteryears, okay, apart from his assistants, there are several people who are standing there and watching him perform surgery. And if you have a closer look at the surgeon, he doesn't have the protective gear like how we used to have, right? He's not wearing gloves. He's just wearing a kitchen apron. So just rolled up his sleeves and he's good to go. So one of the famous surgeons at that time was Robert Liston. His famous dialogue was, "Time me, gentlemen." He used to look up at the audience and tell and ask them to time me. He was known for his swiftness. So he used to complete surgeries within few seconds, and he was very, very proud of it. Now, if you ask any surgeon whether you want to be swift, fast, or meticulous, definitely everyone will choose the second one. Time is not much of essence now, unless and until it's a life-saving or life-threatening emergency. So these were the typical operation theaters which were there. They were just like any other amphitheater with a central table, with a wooden bowl there full of sawdust or mud. So so that the blood, whatever the spills, that spills directly onto the sawdust. So if it is easier to clean. There are rows of seats around with the audience watching the surgery like this. So this is how previous surgeries were done. Why we are talking about this surgeon? Obviously, he was one of the most famous surgeons at that time, a Scottishman. So he was very known for his speed because of the patient's intolerance for pain. Okay, the essence at that time was speed. So he was famously known for amputating or removing a lower limb of a patient with injury in 30 seconds. 30 seconds. Yeah, okay, as less as 30 seconds. I told you. So nowadays, I mean, even however fast we are, it generally takes at least 45 minutes to 1 hour with good anesthesia, everything in just 30 seconds. So, and he is infamously attributed to a surgery with 300% mortality. What happens when you are so fast? Once when he was trying to cut the leg at the thigh region, he accidentally amputated the patient's testicles. In another surgery, okay, any surgery, if you ask what is the mortality, what is the risk of death, okay, it can be as high as 100%, meaning 100% the patient is going to die, or it can be as low as 0%, where the patient has no chance of death, he is most likely to live. But he is infamously attributed to a surgery with 300% mortality. Okay, how 300%? So when he was trying to operate like this, okay, when he was trying to operate like this, you can see the assistant is holding the leg, okay, and he is wielding the knife. When he was trying to cut through the patient's leg, Liston accidentally chopped off assistant 3 fingers also. So what happened? The patient died later because of bleeding and infection. The assistant also developed infection and gangrene, and very sadly, a few weeks later, assistant also died. One of the persons in the audience, he fell down because of shock, and he also died in the operation theater during the surgery. So infamously, Mr. Robert Liston has been attributed with a surgery which has a 300% mortality. So you are operating on one patient, your patient dies, the assistant dies, and one person in the audience also dies. The reason? Because of the speed with which he was operating. And why the speed was essential? It was very essential because there was no pain management at that time. So overcoming pain has long been an important thing to the treating physicians and the surgeons. So not until in the late 1800s, mid 1800s, okay, was the discovery of anesthesia. So it was used famously by William Morton, a dentist. He used it for one of the tooth extractions. Okay. After that, Mr. Henry Bigelow used it at Massachusetts University. Okay. So initially, what was used was ether. Ether was okay given as an inhalation, and patient experienced insensibility. That's what how they describe. Patient did not experience any sensation during the surgery, and it was a big breakthrough in the field of surgery. So, how did it help the surgeons? It helped the surgeons to take a little time longer so that surgery is done more properly and more meticulously. But however, okay, there are some surgeons like Liston who thought speed is the essence of surgery. He thought surgeons have to be fast to be to give a good result. Okay, even with the advent of anesthesia and pain relief, Liston continued to operate like the way he used to operate. Okay, and obviously many times with devastating results. Soon Liston also started using anesthesia. Being a famous surgeon at that time, using when he started using ether anesthesia, obviously every other doctor, every other surgeon wanted to use it, and definitely the use of anesthesia caught up. It was not without complications. Okay, there was a famous story of a dentist using the anesthetic agent to one of his relatives itself. A young girl, he administered ether anesthesia. She continued to have pain. A few more doses were administered, only to note that by the time he finished the procedure, she was pale and stopped with a stopped heart. Okay, there are several anecdotes like this because our knowledge of anesthesia was just beginning at that time. So, however, there was another important change with the advent of anesthesia. So, whenever with the advent of anesthesia, what happened? The surgeons were more daring to operate. The surgeons were more comfortable to operate. So previously, the surgery was done as a kind of last resort. After all the treatment was failed, then surgery was done as a last resort. Now, with the advent of anesthesia and patient being insensible, so surgeons had the dictum, when in doubt, open and see. Meaning, if you feel there is something wrong in the tummy, you don't know what is happening, give anesthesia, cut open the patient's tummy, look inside, find if you can any pathology and correct it. So obviously what started, there are a number of laparotomies or the tummy surgeries which started happening at that time. The numbers start to increase substantially. Okay. So, however, this is the third obstacle which has been overcome. We had knowledge of anatomy, we tried controlling pain, we tried controlling the bleeding. So, these are the three major obstacles which were overcome. So obviously what happened, surgery started becoming a dominant force in the medical field. There were surgical training programs which were established, which were not there till that time. So surgery started growing at a rapid pace compared to the medicine. There were several surgical procedures which were postulated, which were proposed almost every 2 monthly basis. Surgery started growing very fast with the advent of anesthesia. So, however, the problem of infection still remained. So, if you visit any hospital, obviously, maybe most of you would have seen this photograph of hand washing. There are instructions almost at every hand wash area telling the doctors, surgeons, nursing staff, medical students how to wash their hands. Okay. Because now we have realized that hand washing is one of the first and foremost thing which can prevent infection spreading to the patient from the surgeon himself. Okay. So such a simple thing, but however it was not advised or it was not followed in the beginning of the era of surgery. In fact, the earlier surgeons, they just used to walk into the operation theater without gloves, without even washing their hands, and they just used to operate on the patients with the bare hands. Okay. So now one of the first things what a medical student learns is learns after entering into the operation theater is how to wash their hands. You can see there are several photographs here, starting from how to switch on the tap, how to open the soap, and how to wash hands, and how to walk after washing your hands with the hands held high. This is one of the first and foremost things what a surgical resident learns. Okay, so we should be thankful to Mr. Dr. Semmelweis. He is considered as the father of hand washing. Yes, there is a father for hand washing also. He was a famous obstetrician. Okay, because of him, the lives of several mothers were saved. When he was in charge of obstetric ward, he noticed that after the delivery, several mothers used to develop fever. If one patient in the ward developed fever, what used to happen? Subsequently, over a period of days, all the patients in the ward used to develop fever and they used to die. So he thought that maybe the same surgeon who is examining all the patients, if he tries to wash his hands in between the patients. You have seen previously old government hospitals, they have these big bins with antiseptic liquid placed at the corners of the ward for this purpose. Okay, he advised his residents and fellow doctors to wash their hands after seeing one patient and before going and touching the next one. So just a simple act of hand washing brought down the mortality rates, meaning the death rates, by several times. Okay. So he is considered as the father of hand washing. So other important person here is Joseph Lister. He introduced what is called as antisepsis. He used carbolic acid, phenol, and he sprayed it everywhere in the operation theater with the hope that he kills whatever the thing which has been causing infection. At that time, still the knowledge about bacteria, viruses, and other fungi, parasites were very limited. So they didn't know who the enemy was, but they just tried to um, overcome the enemy by using simple methods like hand washing or antisepsis. So with Louis Pasteur and Robert Koch, what happened? The germ theory, okay, was postulated. They discovered that there are some microorganisms which can cause infections. Okay, so with this knowledge, the ability to tackle infection also rose. Okay, along with the advent of antibiotics, the infection rates reduced dramatically. So this is a brief thing about the history of surgery. As we all know, we understand by this surgery was highly invasive. Okay, we are violating the patient's body. Initially, the surgeons faced challenges of lack of anatomical knowledge, lack of control of bleeding, lack of infection control, and pain management. So I briefly discussed with you guys now how these challenges were overcome, how bleeding was controlled, how anesthesia started giving painless surgeries, how infection was controlled, and how the knowledge of anatomy has improved. So after that, there are several eminent surgeons who started operating on everything from head to toe. There were brain surgeries, there were heart surgeries, there were surgeries on the breast, thyroid, intestines. So all the areas were explored and operated upon. And hence there are several surgeons who laid postulates, theories, and operative techniques for all these areas. Okay. So, but the main thing about these surgeries were exposure, meaning the organ has to be fully exposed to operate on it. So, hence the incisions or the length of the opening of a particular organ system was huge. The surgery still was invasive. So, where are we now at present? At present, we are doing what is called as minimally invasive surgery. Okay, right. So you understand now the surgery is actually invasive. Okay, so now we are trying to do what is called as minimally invasive surgery, meaning we are trying to reduce the harmfulness of the surgery to minimum. Okay. So how do we do that? By using several scopies. Okay. Scope means to see. So there were several efforts to explore the human body cavities. Like we had initially a cystoscope where a small tube was introduced along with the tungsten filament, which was heated up inside as a light source to visualize the urinary bladder. So there was otoscope to visualize the ear. There is what is called a cilioscope. Cilioscope means visualizing the inside of the tummy. So these were tried in the initial periods itself. There's something called proctoscope to visualize inside of the rectum also. Similar principles were used to the present minimally invasive surgery. So minimally invasive surgery uses the advanced knowledge along with the previous knowledge of anatomy and surgical techniques. It aims to reduce the surgical stress and resulting disturbances in homeostasis. I think most of you have a fair idea what is homeostasis. So homeostasis means maintaining the internal condition of a body constant without any disturbance. By reducing the stress of the surgery, the disturbance of homeostasis can also be reduced, and hence several advanced advantages. So minimally invasive surgery is also known as laparoscopic surgery. Okay, laparo refers to the abdomen. Endoscopic surgery, endo means inside of a organ. It can be upper gastrointestinal endoscopy where we see the esophagus, stomach, lower intestinal endoscopy where we see the colon. It's also called as keyhole surgery because the incisions are the area where we open into the human body are very small, can be measured in millimeters. So obviously it leaves very less scar, hence it is called as scarless surgery. So what does this mean for the patient? So minimally invasive surgery means we make small incisions. I told you, okay, a few millimeters, 5 millimeters, 9 millimeters, like that. So smaller incisions, smaller wound means obviously for the patient there is less pain. So minimally invasive surgery means we do not handle the tissue which were not supposed to be handled. We directly go into the organ of interest and we operate. So obviously that also disturbs the rest of the organs to the minimum. Smaller wounds, obviously, patients can return to their activity very fast. So smaller incisions means patient can go back to their active lifestyle like driving, lifting, sports, jogging, and to even to the gym. So in the earlier era of surgery, the patients used to stay in the hospital for several months. Okay, they used to stay in the hospital for 3 to 4 months for complete recovery. So then with the advent of modern surgery, it was reduced to few weeks with minimally invasive surgery. So patient can return back home after few hours also. So how does it benefit the surgeon? What does it mean to the surgeon? So now what surgeon has a magnified view. Minimally invasive surgery, we put a camera inside and see what is happening. So we see it on the monitor. So we get a magnified view. So, but however, we cannot touch the organs with our hands. We use the instruments to touch them, so we do not have the tactile sensation. The sensation of tactile sensation is not there. Okay. So other thing is, whatever view we get on the camera is two-dimensional view. Okay. So only problem for the surgeons is it's an entirely different operative technique which we have to learn apart from your regular surgical teaching. Okay. So to understand what is minimal invasive surgery, these are some of the things which you should know. This is called as a trocar and a cannula. So you enter into a patient's body using this, right? We make a small incision. This is around 1 centimeter. Make a small incision, put it inside, okay, and then we enter into the patient's body cavity. So these are the telescopes what we use. This is around 5 millimeters. This is around 1 centimeter. So these things are placed into the hollow here, right? So that we view the inside of the patient's body cavity. This is how the monitors are there. So obviously we will be looking at the monitors and we will be operating just like how you do in the video games. Okay. So previously we used to use instruments like this for open surgeries. There are scissors, forceps, everything. So what changes have to take place now? Now the instruments are longer because we are operating from outside the patient's body. So instruments are longer, almost some 45 centimeters. So with this, you'll get a fair idea. I think this is one of the trocar, like we make a small incision, put it inside. So uh, since there is no place inside, we fill the tummy, abdomen of the stomach with gas. Gas uses carbon dioxide. We get place here. We get a, um, we put a telescope or camera inside and view the internal organs and operate. Okay, this is how it looks from outside, right? So you can see there are several multiple ports which have been put. Okay, 1, 2, 3, 4, 5 like this here, and through the ports, surgeon has introduced instruments. Okay, maybe a couple of instruments the assistant will hold, and surgeon will look at the monitor like this. Okay, with this you will get a fair idea. Okay, so your surgeon looks at the monitor like this and operates. Okay, so obviously what does it mean? A patient can go back home with small bandages like this. Okay, so this is this is done for laparoscopic gallbladder or liver surgery. You can see surgery, I mean, the opening has been done at 4 places, which are very small, okay, which are less than 1 centimeter. Okay, patient can go back home with a scar like this after few months. Okay, so on the left hand side, you can see the surgery which was done before. Okay, maybe for liver or the gallbladder. You can see easily a 20-25 centimeters big wound. Obviously it would have taken several weeks to heal with resulting pain and other comorbidities to the patient. It would have been crippling, but now the same surgery has been done. Okay, after you can see the scars here, 1, 2, okay, one more here. So after few weeks you have to search for the scars. Such is the beauty of minimally invasive surgery. Okay, so minimally invasive surgery, what does it do? It enters into the patient's body at few places like this, small holes, 1 or 2 centimeters maximum. Put the instruments inside and operate like how we used to before. Only thing is you are operating with longer instruments. We are operating with the instruments are entering from outside. Okay, the surgery what is done is similar. Okay, so that is about the laparoscopic surgery. Okay, so now what we have is what is called as single incision laparoscopic surgery. Okay, so surgeons thought instead of putting the instruments at 3 4 different places like this, why can't we put everything together at a one place like the belly button or the umbilicus? Okay, anyway, umbilicus is a scarred area. Another 2 centimeters of incision here should not make much difference. So that's what is being demonstrated here. Okay, this is the patient's belly button. A 2 centimeter incision is made, means it is cut open for a length of about 2 centimeters. So and a multi-port is used. Okay, so what does it mean? So it has several channels like this. You can see 1, 2, 3, 4 channels here. Okay, so through which surgeon can introduce whatever instruments you want instead of opening the tummy at few different places. Okay, now this is called as single incision laparoscopic surgery. So every time what we are trying to do is we are trying to minimize the trauma to the patient because of the surgery itself. So we are trying to minimize the trauma to the patient because of surgery itself. Okay. So this is how, this is a good picture demonstrating how the surgery has evolved. Say same gallbladder surgery, 20 centimeter incision, to the laparoscopic surgery, okay, incision at 4 places, very small again, to single incision laparoscopic surgery where incision is hardly visible. So they would have gone through the umbilicus for about 2 centimeters and it heals very well. Okay. So this is what I was telling you, the surgery being minimally invasive. So inside what we do is the similar technique, but whatever rest of the trauma because of the incision like this has been reduced completely. Okay. So with the advent of telescopes, the ports, everything, okay, so surgeons started exploring other organ systems also. So this is thoracoscopic surgery, means you can enter into the patient's chest, similar to whatever I have shown before, make small openings, put instruments, see inside and operate on the lung or the aorta or the heart. Okay, huh? So this is another extension of this. Okay, so this is called as natural orifice transluminal endoscopic surgery. Don't go by the fancy name of it. So natural orifice means either the patient's rectum or the vagina or the mouth, like this. Here what you can see is this is the uterus. Okay, so here they have entered through the patient's rectum, made a small hole, and a instrument is introduced inside. So through this, we can visualize and you can take out your appendix or gallbladder and other surgeries. Tumors, small tumors can also be removed. So virtually what will happen? There is no incision on the patient's tummy. Okay. So this is another picture demonstrating thyroid removal. Okay. Previously what you used to do, so we used to cut open the patient's neck for about 10 to 12 centimeters like this and operate on the thyroid. So now what they are depicting is called transoral resection of the thyroid. Okay. So the advantage is there is no scar visible here. It's completely less invasive procedure. We are opening the at the gums and introducing instruments and take out the thyroid. So the invasiveness of the surgical procedures has been minimized. Okay, so and hence the surgical stress is reduced, and hence we can think about discharging the patient after several hours of surgery. Patients can go back to their homes very fast, go back to their work very fast, and this results in very less time of their work and their livelihoods. Okay, so this is a very significant development in the evolution of surgery after the discovery of anesthesia. So several surgeries now are being done in minimally invasive ways or laparoscopy and thoracoscopic ways. Okay. So an extension of this is what is called as robotic surgery. Okay. So robotic surgery, the problem with minimally invasive surgery, laparoscopy is again the operator here is the surgeon. Okay. There is chance of fatigue, the surgeon's dexterity. These are all the limitations. So robotic surgery, okay, now instead of surgeon and his assistant arms, so these are what are called as robotic arms with the instruments attached to the tip. This is the patient table. Patient will be lying down here. The robotic arms are fitted with the instruments what are necessary for the surgery. Okay. And where does the surgeon go? Surgeon sits one corner, either in the same operating theater or maybe a adjacent room or in the lobby. Okay. So surgeon sits very comfortably here, right? There is no need to stand for long hours. The fatigue and resulting problems with the surgery are also taken care of. So as you can see, the robotic arm is loaded, okay, and everything is prepped and draped, okay. Surgeon sees through the telescope here present with the robotic arms. Surgeon gets the view now. He has joysticks in his hands. There are a couple of controls on his foot, okay. So he can manipulate each arm here to whatever the degrees of freedom you want, and he can operate, okay. So this allows for higher precision and lack of fatigue for during the surgery. So this is how a robotic surgery unit will look like. Okay, surgeon sits somewhere else comfortably now. Okay, there is no need to stand for long hours. Okay, he sits comfortably here. So this is the robo with his robotic arms. Patient is anesthetized. The nurse goes and gets docks the robo like this. So after that, surgeon can sit and operate. Okay. So this is what we are now. This is what we are doing now. We are doing laparoscopy. We are doing thoracoscopy. We are doing natural orifice surgeries. All these things we have started doing. robotic surgeries, though lesser in number also. Okay, so this is where the current surgical evolution is. Okay, so what next? So from being highly invasive, okay, we have turned to minimally invasive surgery. What next? Next maybe next evolution might bring the elimination of invasion. Okay, there might be some techniques where violation of patient's body might not be essential. Okay, they might devise small devices which can go and operate at the site where it is actually required. Okay, surgical work can be fully automated. One of the advances which has been put into use is what is called as capsule endoscopy, though it is only diagnostic, meaning it is not interventional, it doesn't go and operate. Okay, so it just helps to diagnose things, it helps to diagnose the diseases. Okay, several companies have come up with capsule endoscopies. Okay, like I told you, endoscopy means inserting a flexible tube inside the natural orifice. Most of the times we get a upper gastrointestinal endoscopy where a tube is passed into your mouth, into the esophagus, into the stomach, and the inside of the stomach and esophagus is seen with the camera to diagnose the disease. Same thing can be now done by what is called as capsule endoscopy. This is a size of just like any other capsule. It has got a chip inside, it has got a camera inside, it has got a light source inside. Patient has to just swallow this. There will be a transmitter from this, and there will be a receiver which is attached to the patient's body for about 8 hours. So all the images, the data from captured by this, as the capsule is being passed through the intestine, is received, and it is analyzed using a computer software. So other thing which we have been trying to do is called as remote robotic surgery, or what is called as telesurgery. Okay. Anyway, tele denotes distance. Okay. So the technology now has, and with the advent of wireless networking, the 5G, everything. Okay. So there have been several instances which have been tried to operate on a patient. Okay. So to control the robo, okay, sitting from a far away place. Okay. Robotic technology and wireless networking have made it possible. Okay, it has allowed surgeons to operate on the patients who are very, very far away. Okay, maybe a different country or a different city altogether. Okay, so how does it help? It helps overcome shortage of surgeons. There are some third world countries where the surgical expertise is very poor, no proper number of surgeons, so that can be eliminated. Okay, so supposing it eliminates geographical barriers, expertise which is present, say in Bangalore, to a patient who is present in a far-flung area can be eliminated. So for the surgeon, it can eliminate hand tremors. For operating for longer times, what will happen? Surgeons can develop tremors, which can have a bearing on the surgery, what they do. Since it is a robot, okay, it can eliminate that using some special softwares. Okay. But the drawback is tactile feedback. Most of these times, we surgeons rely on tactile feedback. We touch the tissue for the tactile sensation. So, and then many a times pathology is diagnosed, that is lost here. And the biggest problem with the telesurgery operating from far away is the latency period. You can ask the robo to do a particular maneuver, okay, but the signal has to be carried through wireless networking, optical fibers, everything. There is some latency period from the time you give command and till the time the robo performs the act. If that latency period crosses a particular beyond a particular barrier, okay, so then the surgery becomes very tedious. Okay, so what next in the future for us? This is called as nano robotics, is a exciting field, advent of nanotechnology. So people have tried to design nano robots which are of very, very small size. This, as you can see, this is a red blood cell in the blood. Okay, a robo comparatively of similar size which can be injected into the particular bloodstream, patient's bloodstream. So it travels within the blood, identifies the tissue or the cells which are sick. Okay, and it can try to treat it, or at least now it can be used to help diagnose the cells, especially cancer cells. Okay, the robo can help to remove the obstructions in the blood vessels. For example, obstruction in the blood vessel, block in the blood vessel can cause heart attack or gangrene. Those things can be taken care of, at least is hoped to being taken care of. So it is a surgery at a cellular level. Okay, so other interesting thing is tissue engineering and bioprinting. With the advent of 3D printing technologies, the biologist along with the biomedical team, they have been trying to do tissue engineering or bioprinting to harvest, artificially produce certain organs, at least a part of the organs, say maybe larynx or trachea or so like that. Okay, so that is an exciting field for the future surgeons. Okay, so with these interventions, these are the four cornerstones of future of surgery as displayed in the website by Royal College of Surgeons, Edinburgh. Okay, so they told minimal invasive surgery is the basis for all the future development. Okay, but further developments can come from genomics. We can operate at a cellular or a molecular level now. Okay, so imaging, artificial reality, and augmented reality, sorry, and virtual reality, okay, are the future for the development, and with specialized and specific interventions at maybe cellular or chromosomal levels. Okay, so what is in store for us now? Okay, we don't know how many of these things will actually come into practice. Okay, at a mass level. Okay, but however, with the advent of minimal invasive surgery and robotic surgery, okay, the surgeon is being pushed far away from the patient. Okay, so obviously the entire medical profession, medical field has been built on the kind of human relationship between the surgeon and the patient that is being lost continuously. So what is in the store for us? Okay, maybe a further few years or decades can tell. Okay, thank you very much for patient hearing. Just before yeah. So just before I wind up, I will just like to play a small video. This is one of the from one of the famous laparoscopic surgeons, pioneers from India. Okay, a mentor for many surgeons like me. So this is how a laparoscopic minimal invasive surgery looks like. Okay, so this is the inside of a patient's tummy. This is the appendix, what the surgeon is holding. So this is the large intestine in the beginning. Okay, this is how the long instruments will go and hold the appendix, right? So here comes another instrument. Okay, so and whatever necessary, see there are energy sources also now. Previously we used to tie off these blood vessels, tiny red color blood vessels, you can see. So previously we used to tie it off. Now with very good energy sources, you can see the surgeon, so just using a high energy source to cut the tissues off. So once that is done, this is the scissors which has entered. So once that is done, okay, we tie off the appendix or any other organ involved in minimal invasive surgery now. So, and you can see again energy is being used to cut it off. Okay. So there are several modifications which have been done, but what I want to observe is there is a big space which is created in the tummy because we have put gas inside, carbon dioxide. So this is how the tip of the instruments almost remain like any other um, instruments we use for open surgeries, but they are very, very longer now, right? So one more. Yeah, one last thing, please. Can you see this now? Hello.
Yes, we can see it.
Yeah. So what I want to observe now is robotic surgery, the nuances of it. Okay, so there's a surgeon sitting at a faraway place now. This is called as the Da Vinci system for the robo. Okay, he's holding the joysticks. Okay, he's comfortably sitting just like any office there. Okay, and what I want you to observe is the dexterity of movements possible with the robotic arms. the tip of the instrument can turn virtually 360 degrees. Okay, unlike in the rigid instrument what we used to use, see it is almost turned at a acute angle now. Okay, so the tip of the instrument virtually can turn in any ways. This has made possible the surgeon's ability to reach at far-flung difficult areas also. That's how the robotic surgery helps now. Again, the same appendicectomy being demonstrated here. Okay, so obviously the surgeon is a little slow because these are the few newer things which have been come. Okay, yeah, I think that should be. Okay, that's it. I think hope you got a fair idea of what minimally invasive surgery is. So what the surgeons are doing now and what the future is in store, okay, for the surgeon field. Thank you. If you have any questions, I would be more than happy to take them now.
Students, if you have any questions, you can unmute yourself and ask.
Hello.
Santosh,
Ma'am.
you said you fill the stomach with, I mean, if it's a laparoscopy,
Yeah.
with carbon dioxide, is there
Exactly.
one use for carbon dioxide or multiple uses?
Ma'am, when we started doing laparoscopic surgery, the problem was lack of space. We cannot put you, like you have seen, there are long instruments and which require a lot of space to work around. Okay. So what they thought was they to get more space, they have to fill up the abdomen, tummy, stomach here with gas. Okay. They tried several gases. There are several features of the gas which were looked into. Okay. The gas has to be inert. It should not be absorbed into the body, otherwise it will cause a lot of harmful effects. And like you have seen, we use energy sources, we use electrical current to burn the tissues there. So the gas should not cause fire also inside. So these are several things which were looked into. Helium was tried, just the room air was tried. Okay, so after everything, the carbon dioxide is the most settled and used gas now. Okay, it is inert, it gets absorbed, yes, but within 48 hours, whatever the little absorption has happened into the bloodstream, everything will be okay, washed away by our respiratory system. So, and it doesn't catch fire also. So these were things which were looked into, and carbon dioxide was settled on.
Thank you.
Thank you, ma'am.
Okay, Dr. Santosh,
Yes, ma'am.
very nice collection, very nice explanation you gave.
Thanks a lot, ma'am.
Really, we thank God we are in 21st century, because the beginning, what explanation you gave, no,
Yeah.
that surgeons felt very,
Correct.
and then very happy to see your smiling face with such a serious surgical field also.
Yeah.
And then that capsule treatment, something you told, is it practice or is?
Yeah, I mean, that's what I stressed on. Capsule endoscopy, we are doing it now. So
Okay.
just like any other endoscopy, basically endoscopy means we are trying to look into a hollow organ. In this case, the intestine.
Yeah.
So when we put a tube or a camera into the mouth, we can just see the upper part of the intestine, the stomach and the esophagus. We cannot go beyond that. So we put a tube, we do what is called as colonoscopy, where we put camera endoscope into the rectum, and we can see the distal part. The central small intestine is very, very difficult to assess. For that, we rely on so many things. Sometimes if you had any doubt, for example, if you suspect that there is some bleeding into the small intestine, many a times we used to do surgery and inspect the intestine visually. So that's what we used to do. Now with capsule endoscopy, what we do is whatever the work the endoscope does, the capsule does now. We ask the patient to swallow it. It has got a small camera. It has got a light source also. Just like any other food, what you take, it what happens? It goes into the esophagus. It goes into the stomach. Okay, so it starts clicking pictures there and transmitting into the receiver. So once the data is collected, it is examined to check for any pathology. You can find if there are any ulcers, if there is any tumor, or if there is any bleeding. So now treatment with this capsule endoscopy is still not much developed. We cannot go and treat there. It is still in the diagnostic phases. Other thing, like any other new procedure, is the cost. Okay, it almost costs more than half a lakh. Otherwise, regular endoscopy is what, around 2,000 or okay, 2 to 3,000. This must cost higher than 50,000. Okay, and that is only one thing which is the factor now. And we are unable to treat with along with the capsule endoscope. Okay, maybe in future, like I told, with small robotic things, we can take a biopsy and we can start treating also.
Okay, thank you.
Thank you.
So that was a wonderful presentation where you have taken us through the past, present, future aspects of surgery. And I wonder if all of these would benefit the people in a country such as ours. Will the people be able to afford such kind of surgical practices?
Yeah, same question was asked when laparoscopy was came into the vogue. Laparoscopy, as you can see, it developed in late 90s. Means it is just 25, 30 year old, 25, 30 years old. Now, even if you go to a small hospital, also they have a laparoscopic setup. Okay, so the main thing in our field, the cost is reduced once the number of hospitals start using it and number of patients start using it. Okay, so if the number of patients there's some problem. I did something.
No, it's okay.
It's
I
okay.
think the video is over.
Yeah, video is over.
Yeah,
Yeah.
no problem.
So I think definitely now laparoscopic surgeries are easily affordable. Okay, sometimes the cost is comparable to the open surgeries, and we give the additional benefit to the patients of going back to their homes very fast and going back to their work very fast. There is no loss of revenue for the patients also. Instead of getting a open surgery and staying at home for 2-3 weeks, okay, patients, especially many patients who come to me are software engineers. If I remove gallbladder today, maybe day after tomorrow, they can sit at their desk and start working, which was unheard of a couple of decades back. So that is the advantage. Okay, so cost benefit, I think we should assess like this. Robotic surgery right now, not many hospitals also can afford it. Okay, the cost of establishing a robotic unit, okay, is enormous. Okay, the cost of the robotic console is more, and the cost of training a surgeon to become a robotic surgeon is also more. Okay, and the number of surgeries which we are doing with the robo now are quite limited, meaning it is still not the gold standard for many of the procedures. So maybe another 2-3 decades, I think, just like laparoscopy, which is available everywhere, robotic consoles are also will be available. Okay, and I think the cost also will come down dramatically at that time.
Thank you, sir. Now I'd request the students, I am sure you have been inspired by this wonderful presentation. In case you have anything interesting to be discussed, you may share your thoughts now.
May I speak, ma'am?
Yeah, please introduce yourself and then go ahead.
Okay. I'm Tejas from second PUA, ma'am.
Yeah.
So this has been very relatable to me because when I've undergone laparoscopic surgery on my appendix
Yeah.
6 to 7 years ago.
Correct.
So I didn't understand how the inside thing works. Now that your sir has shown this, so now I have a clear idea about what exactly has happened and how the thing works.
Yeah,
So
exactly.
thanks a lot for sharing this information and also on the history of surgery,
Yeah.
especially about Robert Lister and Louis Pasteur.
Correct. Yeah. So yeah. So one of you have got the advantage of laparoscopic surgery already. Yeah, it's like hardly you cannot find someone who has not been exposed to laparoscopy nowadays. Yeah.
Correct, sir. Correct.
Yeah.
Dr. Santosh,
Yes, ma'am.
this laparoscopic surgery,
Huh.
can it be used to correct all kinds of conditions, or do we still have to depend on conventional surgery for correcting certain,
Yeah,
conditions?
that's an excellent question, actually. Okay, so can we do all surgeries by laparoscopy? Yes, we can do. Do we do all surgeries by laparoscopy only? No. Okay, there are some surgical conditions where laparoscopic surgery is the gold standard. Meaning if I don't offer the laparoscopic surgery to the patient, okay, I will be doing injustice to them. There are some surgeries, there are some diseases where laparoscopic surgery is the gold standard. For example, gallbladder removal, which is very common. Okay, so gallbladder removal, if you go to any surgeon, any place, any country, the treatment of choice is laparoscopic surgery only. Likewise, there are some other surgeries, for example, maybe hernias. Okay, still laparoscopy is not considered a gold standard. Okay, like I told you, laparoscopic surgery is still 2-3 decades old. Okay, so before something becomes a gold standard for treating a disease, okay, it has to go through a lot of scrutiny. Okay, a lot of randomized trials to be done. So once it is known that we can offer substantial benefit to the patients, okay, then only it kind of becomes a gold standard. Okay, so see, I can do a hernia laparoscopically, but is it good for the patient is the question what we should ask now. Okay, so part of the question ma'am asked is whether all surgeries can be done laparoscopically. Yes, all surgeries can be done laparoscopically. In fact, few of the surgeries, because of the morbidity, means because of the trauma with the open surgery caused, in fact, we have abandoned those surgeries. Nowadays, those surgeries also have come back to vogue because of laparoscopic surgery. For example, you would have heard about gastroesophageal reflux disease, where the acid from the stomach refluxes comes back into the esophagus. Patient has heartburn. Okay, so the surgery we do for this disease, okay, it had carried a lot of morbidity. Okay, so a lot of patient difficulties post-operatively. Now with laparoscopy, all that is taken care of, and it is being done widely now. Okay, so there are several surgeries which have been making a comeback. Okay, everything can be done laparoscopically. Okay, few cancer surgeries, okay, they are still debatable, because cancer surgeries, the main aim is to remove the entire cancer without leaving anything behind. So the problem with laparoscopic surgeries is we make very small holes. How to take the cancer out if it is very big? Okay, so there are several things what we do also, but in cancer surgery, okay, it is kind of slightly debatable. Okay, but virtually everything can be done laparoscopically now.
Thank you.
Yeah, even it is interesting to know that there is something called minimally invasive cardiac surgery also. So previously the bypass surgeries, they used to cut open the patient's chest, okay, the sternum, the center of the chest. Now the bypass surgeries in selected patients can be done with a small 5 to 6 centimeters wound. Okay, so obviously it's a big advantage to the patient.
Dr. Santosh, could you tell a little bit about, in brief, about cryogenic procedures?
Yeah, cryotherapy. Okay, well, I mean, so this comes broadly in the heading of energy sources what we have used for surgeries. Okay, like I showed you here, it's one of electrical current. What we used in a couple of videos, what I showed, to generate the amount of heat to burn the tissues. Okay, why are we burning the tissues? Either through cut through them or to stop bleeding from them. Okay, instead of tying many knots, this is what we have been using. Like that, we use ultrasonic shears also. There are some small instruments which the tips of them, they vibrate at almost 30,000 to 50,000 times per second. Okay, so we use that ultrasonic energy to do the same thing. We use laser also to do the same thing. Similarly, we use cryotherapy. Okay, I mean, the cryotherapy meaning we use temperatures at minus 40 degrees or so. Okay, we desiccate the tissue, we burn the tissue so that there is no bleeding, and sometimes the treatment is also done along with that, especially if the tissue has a lot of blood vessels. Okay, if it is vascular, like esophageal varix, I mean esophagus, when sometimes in alcoholics, when the blood vessels dilate, okay, we can use cryotherapy to just burn them. Okay, again, this can be a part of surgery which is minimally invasive. So instead of cutting the tissue out, we can just use a energy source, okay, to desiccate the tissue, denature the proteins, and once you cut the tissue, the trauma stress is more, and obviously that is much lesser now.
Thank you.
Thank you.
Anybody else who would like to ask any points related to surgery? Future doctors and the participants, I'm sure would be inspired to continue with the future prospects of minimal
Yeah,
invasive
many
surgery.
become surgeons also, maybe.
Okay, thank you so much, sir. for having helped us understand the evolution of surgery in a bird's eye view. I shall now request Seema from the Department of Biology to present the vote of thanks.
Good afternoon. Respected Speaker, Dr. Santosh MP, Principal Ma'am and Vice Principal Ma'am, it is my privilege to propose the vote of thanks on this occasion. It has been a pleasure for us to have our alumni to speak in this webinar. Sir, we are extremely grateful to you for having consented to share your wisdom regarding this minimally invasive surgery. Even though you have the several professional commitments, we appreciate that you have taken time off to honor our invitation. Today, we have been well informed about the evolution of surgery with the knowledge of anatomy, management of pain, the control of bleeding, infection, and also know the various advantages of invasive surgical techniques like robotic surgery and the future surgical remote robotic surgery and nano robotics. So it is impossible to express our gratitude just in few words. Thank you once again, sir. Our gratitude is due to our beloved principal Sunita ma'am and vice principal Shantala ma'am for their constant support and encouragement. I would like to extend my heartfelt gratitude to my all colleagues, non-teaching staff, students, and all other participants. My special thanks goes to the technical team for their support. Once again, I would like to thank one and all for your active participation in making this a meaningful event. Thank you. Have a nice day, sir.
Thank you very much. May I speak a few words? No.
Yeah, sure.
Yeah, thank you, ma'am. It was very nice seeing you after a long time. Okay. I still, remember the drawings you used to draw on the blackboard. I used to tell my parents also, like, how good you are. Okay, thanks a lot, ma'am. Thank you, Anandi ma'am, also, and other teachers. And thank you, Radhika ma'am. I think without her, I wouldn't have been able to present, I think. Okay, I'm very poor with these things. Okay, she helped me a lot. Thanks a lot. Thank you.